Welcome to the Deep Dive. Today, we are getting right into Chapter 54 from our source material, Drugs Acting on the Upper Respiratory Tract. And this is really essential stuff. We're going to break down the 5 core classes of meds that basically keep our airways open and working. So our mission today, really, is to give you a functional shortcut. We want you to understand not just what these drugs do, but how they do it, the mechanism of action, and more importantly, the nursing considerations for these medications that are, everywhere.
They really are. And to get started, we need a solid foundation. Let's define our 5 pharmacological pillars. Think of them as 5 essential tools in the respiratory toolbox. First up, you have your antihistamines. They block histamine, that chemical that causes all the swelling and sneezing in an allergic reaction.
It blocks the allergy.
Exactly. Then number 2, antitussives. These are cough suppressants. They literally block the cough reflex.
The cough.
Third, decongestants. They cause vasoconstriction, so they shrink those swollen membranes and dry things up. Fourth are the expectorants. They do the opposite, in a way. They make your cough more productive by thinning out secretions.
So they help you cough things up.
Right. And finally, mucolytics. These are the heavy-duty ones. They're designed to break down really thick, stubborn mucus.
Okay, but before we dive into the first class, we have to talk about the biggest trap with these drugs. Rebound congestion.
Yes. The technical term is rhinitis medicamentosa, and it is such a vicious cycle.
How does that actually happen?
Well, a patient uses a topical decongestant spray, right, and they get instant relief. But when the drug wears off, the body overcompensates. You get this massive vasodilation, and the congestion comes roaring back, even worse than before.
So they use the spray again.
They have to. And that cycle can start in just, 3 to 5 days of overuse. We have to warn our patients about this.
Okay, that's a huge point. Let's unpack that first class now.
Yeah.
Antitussives. So these are for those really annoying, unproductive coughs you get with a cold. But the big rule is if a cough is persistent, you have to find out why before you just suppress it.
100%. And they work in 2 main ways. Most are centrally acting. So they go to the brain and they depress the cough center in the medulla.
Okay, so that's drugs like codeine, hydrocodone, and dextromethorphan, which is in almost everything over the counter.
Exactly. They're all hitting that off switch in the brain.
And the other way.
That's the locally acting ones like benzonatate. It works like a local anesthetic. It numbs the stretch receptors in the respiratory passages that are telling your brain to cough.
So it never even sends the signal.
It stops the signal right at the source. And that leads right into the biggest contraindication. You absolutely do not give an antitussive to a patient who needs to cough to keep their airway clear.
Like a post-op patient, abdominal or thoracic surgery.
Precisely. If they can't cough up secretions, you're risking major complications. Same goes for patients with asthma or emphysema. Accumulating secretions is already a huge danger for them.
And what about interactions? The centrally acting ones, they're working in the brain, so you're going to get some CNS depression, drowsiness, sedation.
Yeah, and the drying effects, too. Dry mouth, constipation.
But the really dangerous one is dextromethorphan with MAO inhibitors, right?
That's a life-threatening combination. You can see extremely high fever, severe hypotension, even coma. It's a huge risk for serotonin syndrome. You just don't mix them.
Yeah.
And this ties right into a major lifespan alert from the text, box 54.1. Cough and cold meds should not be used in kids under 4, period. And with extreme caution for kids between 4 and 6.
Because parents might accidentally overdose them.
Yes. They'll give them, a cough syrup and an allergy medicine, not realizing they both have the same active ingredients. We have to teach them to read every single label.
That's a perfect transition to our second class. Decongestants. We've suppressed the cough, but now we need to deal with all the swelling and mucus.
Right, and these are mostly adrenergics or sympathomimetics. They mimic the fight-or-flight response.
They cause vasoconstriction. They shrink everything down.
Exactly, and you can deliver them topically or orally. The topical nasal decongestants, like oxymetazoline, work almost instantly.
But there's the catch.
There's the catch.
That immediate relief comes with that huge risk of rebound congestion. Use it for more than 3 to 5 days, and you're almost certainly going to get trapped in that cycle.
And teaching proper technique is so important here. The text mentions this in box 54.2. The patient should be sitting upright, head tilted back, and sprayed gently.
You don't want them squeezing the bottle so hard it shoots up into their sinuses.
No, definitely not. And you also need to check for any sores or lesions inside the nose because that could let the drug get absorbed systemically.
Which brings us to the side effects. Even with a topical, you can get systemic effects, especially in high-risk patients. Increased heart rate, higher blood pressure.
Right, because it's mimicking adrenaline. So anyone with a glaucoma, hypertension, thyroid issues, heart disease, you have to be so careful. Now, when we switch to the oral decongestants like pseudoephedrine, the action is similar.
But it's systemic from the get-go.
Exactly. So those side effects we just talked about, they're much more likely. You'll see anxiety, restlessness, tremors, palpitations, high blood pressure.
And this is the stuff that's now kept behind the counter, right?
Yeah.
Because it can be used to make meth.
That's right. The text points this out in box 54.3. After they pulled PPA from the market, pseudoephedrine became the main one, but it's highly regulated now for that very reason.
Which really highlights the key implementation point for us.
Hmm.
Tell patients to read the labels. So many OTC cold products have pseudoephedrine in them, and it's incredibly easy to accidentally overdose by taking two different products at the same time.
You're stacking the same powerful stimulant without even knowing it. The third strategy here is the topical nasal steroids. Fluticasone, flunisolide, these are for more chronic issues like allergic rhinitis. They're direct, local anti-inflammatories.
And here's the big patient education piece. They're not immediate.
Not at all.
You have to tell them you won't feel relief for a few days, maybe even a week.
Yeah.
If nothing changes after 3 weeks, they should stop taking it. Managing that expectation is key.
Absolutely. And because steroids block the immune response, you don't use them if there's an active infection. You could actually make it worse. We even see an increased risk of Candida albicans, like a yeast infection, in the nose.
And that leads to a bigger systemic risk, doesn't it?
It does. Patients using these should actively avoid people with airborne infections, like chickenpox or measles. Their immune response is dampened, even from just a topical steroid.
Okay, let's pivot to our third class. Antihistamines. These are the ones that block histamine at the H1 receptor sites to stop that allergic response.
And the generational difference is everything here. First generation, like diphenhydramine, Benadryl. It crosses the blood-brain barrier easily, which is why it causes so much drowsiness and sedation.
While the second generation cetirizine, fexofenadine are designed to be less sedating.
Much less sedating for most people, yes.
You know, the critical thinking scenario in the text with K.E., the businessman, is such a perfect example of why this matters.
There really is.
He's just trying to get through his cold, taking multiple OTC products, and ends up with severe dizziness and drowsiness because he's accidentally combined all these drugs and reached toxic levels.
It's a safety trap just waiting for an unsuspecting patient. And we have to mention the major cardiac safety alert. Some of these antihistamines can prolong the QT interval on an EKG. So in patients with a history of arrhythmias, you have to be extremely cautious.
Wow. So it's not just about being sleepy.
No, we're talking about the risk of fatal cardiac arrhythmias. It's serious.
And beyond that, the more common side effects are all related to those anticholinergic properties. The drowsiness, the dry mouth, GI upset, and importantly, urinary hesitancy.
Which leads to some really practical nursing tips. If you can, give it on an empty stomach to help absorption. Suggest sugarless candies for the dry mouth.
And have the patient try to void before each dose, right, to minimize that urinary retention problem.
That's a great tip. It really helps.
Okay, so we're shifting gears for our last section. We've talked about stopping coughs and drying things up. Now we're talking about actively clearing out thick secretions with expectorants and mucolytics.
Exactly. We're moving from suppressing to expelling. So expectorants, which is mostly guaifenesin, work by making the cough more productive.
How does it do that?
It's pretty clever. It reduces the adhesiveness and surface tension of the secretions in your lower respiratory tract. It basically just thins the mucus so you can cough it up and out.
But the key safety warning is, don't use it for more than a week.
Right. If that cough is still there after a week, it could be masking something much more serious that needs to be checked out. And then we have the mucolytics. Acetylcysteine and Dornase alpha. These are for our really high-risk patients, COPD, cystic fibrosis, pneumonia, people with that thick, tenacious mucus that just won't move.
Acetylcysteine is a fascinating one. It has that dual action.
It does. Primarily for breathing, it works by splitting the disulfide bonds that hold the mucus together. It literally breaks it apart.
But it's also the antidote for acetaminophen overdose.
It is. Used orally, it protects the liver from Tylenol toxicity, a very versatile drug. Dornase alpha, on the other hand, is highly specialized. It's used for cystic fibrosis because the mucus in CF patients is full of extracellular DNA, and this drug specifically breaks that down.
So for nursing care with Dornase alpha.
You have to stress that it's palliative. It helps, but they must continue all their other therapies like chest physiotherapy. It's not a cure.
And a quick practical note on administering acetylcysteine. If it's given by face mask, you have to wipe the residue off the patient's skin right away.
Yes, with plain water. That residue is sticky and can cause skin irritation and breakdown if you leave it on. So, to pull it all together, we've covered our 5 tools. Antitussives to suppress, decongestants to vasoconstrict, antihistamines to block the allergy, expectorants to make coughs productive, and mucolytics to break down the tough stuff.
And the absolute core takeaway for everyone listening has to be the responsibility that comes with OTC products. Almost all these cold and allergy remedies are combinations of these drugs.
An antihistamine with pseudoephedrine, an antitussive with an expectorant.
So patients must read the labels. They have to know what they're taking to avoid that accidental overdose, just like in that KE scenario.
And my final thought, to build on that idea of vigilance, goes back to those nasal steroids.
Right.
The fact that a local topical spray can suppress the immune response enough that we need to warn patients to avoid systemic infections like chickenpox, that's a powerful lesson. It shows how a seemingly simple treatment connects directly to a patient's broader health and safety in their everyday life. That connection requires continuous vigilance from us.
That's a fantastic point. It's a crucial perspective. Go apply this knowledge, read those labels, and we'll catch you on the next deep dive.